Hello everyone, I am Sarita Rawat, Assistant Professor, School of Pharmacy, Suresh Gyan Vihar University, Jaipur, Rajasthan. Today's our next lecture of pharmacology. Today's our topic is anti-leprotic drug. So the drug that are used in leprosy, we will study today. So learning objective of today's lecture is definition, causes, drug classification and drug to be avoided and conclusion of leprosy. Now, learning outcomes of today's lecture is you are able to know about the symptoms, the range of drug that are used for leprosy, and also you are able to report the application, side effect, toxicities, and drug interactions in the leprosy, and you are also know about the treatment principle of the leprosy. Now, as you can see, this is the image of a person having leprosy. Basically, the leprosy can be caused by the Mycobacterium leprae. So, this is the causative agent for leprosy. It is a strongly acid-fast roadside bacteria and also known as Hansen disease. After the scientist who discovered M. leprae in 1873, it is known as Hansen disease, and it has a long incubation period which is 3 to 5 years. Now, primarily it affects the superficial tissue, especially the skin and the peripheral nerves. So, as you can see in this picture, the skin of the person is very damaged. Now, a leprosy patient is someone who has a skin patches or patches with a definite loss of sensation. So the person who have leprosy, like they have skin patches and the patches has no sensation. Then leprosy patches can be pale or reddish and of the copper color. It can be flat or raised. It do not touch it. Usually do not hurt, and it is do not when we touch the patches, it doesn't hurt the patient because it has loss of sensation, and it also not itches. Now, lack of sensations to heat also and touch or pain. So whenever it come into the contact with the temperature or heat, fire, so it did not give the sensation of heat, touch or pain, and it can appear anywhere in the body or skin surface. Now, as you can see, this is the leprosy patches and can be pale or reddish or copper colored. So, as you can see, this is the pale color patches, and this is the reddish patches, and this is in the copper color patches. So, it can be flat or raised. So, as you can see, this is the flat patches and this is the raised patches. Now, these are some another pictures for leprosy. So, as you can see, these are the leprosy patches. Usually do not hurt the person who are having this, and lack of sensation to heat and touch or pain. So it can be appear anywhere in the body. So as you can see, it can be anywhere in the body. Do not itches. And leprosy can be diagnosed on the clinical sign alone. And as you can see, this is the raised patches. Now, peripheral nerve thickening in the leprosy. So as you can see, this is the peripheral nerve thickening in the patient having leprosy. Now, as you can see, hand deformities in leprosy. So the person with hand deformity is suffering from leprosy. Now, the classification of the drug that are used in leprosy included sulfone and dapsone. Dapsone we also known as DDS. So sulfone included phenazine derivatives, anti-tubercular drug, and other antibiotics. Then dapsone included chlorpheniramine, rifampicin, ethanomide, ofloxacin, moxifloxacin, minocycline, clarithromycin. Now, when we talk about the dapsone part, so dapsone is diamino diphenyl sulfone. So that's why it is known as DDS. Simplest, oldest, cheapest, and most effective drug, and most commonly used member of this class for leprosy. Now, the mechanism of action of dapsone included inhibition of PABA, that is incorporation into the folic acid by folate synthesis. Now, dapsone resistance among M. leprosy first noted in 1964, and it has spread and has necessitated the use of multi-drug therapy in MDT. So, in 1964, what happened? The dapsone resistance occurred among the leprosy patient. So that's how the multi-drug necessity came from the 1964 during the dapsone resistance among M. leprosy. Now, as you can see, this is the dapsone resistance. So primarily and second persistent. So when we say primarily, and the infection was contacted from a patient hair burning resistance bacilli. So secondary, it can cause resistance with develops during monotherapy in an individual patient with the dapsone, and persistent therapy during sensitive bacilli which become dominant, hide in some tissues, and are not affected by any drug. And they are stage a comeback after the drug is withdrawn. Now, when we talk about the dapsone, its pharmacokinetic included. Dapsone is commonly absorbed after oral administration and is widely distributed in the body through penetration in the CSF is poor, and the plasma T half is of dapsone is variable through often more than 24 hours. Now, dapsone adverse effect included mild hemolytic anemia, gastric intolerance, cutaneous reactions, that is allergic rashes, fixed drug eruptions, hypermelanosis, phototoxicity, and rarely effoliative dermatitis. So, hepatitis and A granulocytosis are very rare complications with dapsone. Now, when we see dapsone, so sulfone syndrome can occur and develops with the use of dapsone in 4 to 6 weeks after starting the dapsone treatment. And it consists of fever, malaise, lymph node enlargement, disqualimenting of the skin, and jaundice and anemia. So its treatment consists of stopping dapsone immediately and installing the corticosteroid therapy along with the supportive measure. Now, contraindications of dapsone included dapsone should not be used in the patient with severe anemia. That is, if there is a hemoglobin less than 7 gram per dl. And G6PD deficiency. So those person who has G6PD deficiency, dapsone is not recommended. Then those person who are having hypersensitivity reactions, dapsone is not recommended. Now the next drug we have is chlorpheniramine. So chlorpheniramine is also known as CLO. And it is a dye with the leprostatic and anti-inflammatory properties. Now, CLO is the protective mechanism of anti-leprotic actions of clofazimine are interfere with the template function of the DNA in M. lepri, then alteration of membrane structure and its transport function, disruptions of mitochondrial electron transport channel, and orally active 40 to 70% absorbed, and it accumulate in the microphage and get deposited in many tissue including subcutaneous fat as needle shaped crystals. So this is the side effect, and enter into the CSF very poorly. The TR for the clofazimine is 70 days, so that it enter treatment therapy is also possible. Now, clofazimine, because of its anti-inflammatory property, it is valuable in the lepra reactions. When we talk about its adverse effects, so in skin, it can cause reddish black discolorations of skin, discolorations of hair and body, secretions, and also dryness of the skin, and it can cause itching also. Acne form eruptions also caused by this, and phototoxicity reactions it can also occur. Now, the side effects included early syndrome. So it can cause early syndrome like nausea, anorexia, abdominal pain, weight loss, and enteritis with the intermediate loss of stools. Then in late syndrome, it can cause deposition of clofazimine crystal in the intestinal submucosa. Now, next drug we have rifampicin. It is also used in tuberculosis. Most potent cytal drug for M. lepri. Rifampicin remain effective in leprosy even if given for only once a month. And it should not be given to the patient with the hepatic oral renal dysfunction, as well as during the erythroma, nudosma, leprosma, ENL. So erythroma, nudosm, leprosum, so which is known as ENL, and a reversible reaction in leprosy patient because it can release the large quantities of mycobacterial antigens by inducing rapid bacilli killing. Now, when we talk about the ofloxacin, so it is a sidle to the M. lepri. It can be used in the alternative regimen in case rifampicin cannot be used. To shorten the duration of the treatment, it is also used, and reduce the chances of drug resistance, we can use ofloxacin in leprosy. Now, the next drug is minocycline. So, minocycline, because of its high lipophilicity, this tetracycline penetrates into the M. lepri, and vitiligo is the only serious complications of this long-term use. Now, it is being tried to in the alternative multi-drug treatment regimen. Now, the next drug is clithromycin. So, clithromycin is less bactericidal than the rifampicin, and it is being induced in alternative multi-drug therapy regimens. Now, though the burden of leprosy has fallen drastically after the introduction of multi-drug therapy both globally and in the India. So WHO data in 2010 shows that 65% of all new leprosy cases world over are from the India. Now, NLEP 2009 classification of leprosy included bacilli leprosy and multibacilli leprosy. So bacilli leprosy is known as PB and multibacilli leprosy is known as MB. So when we talk about the PB, so it has 1 to 5 skin lesions, no nerve and only one nerve involvement in this PB, plus 1 to 5 skin lesions. Skin similar negative, smear is negative at all the sites. When we talk about the multibacilli leprosy, so it has 6 or more skin lesions, irrespectively of number of skin lesions. Skin smear positive at any one site of the multibacilli leprosy. Now, as you can see, this is the example of multibacilli and pubibacilli leprosy. So the first one is 1 to 5 patches, and is it a pubibacilli or leprosy treatment? 6 PB blister packs. Now, more than 5 patches means it is a multibacilli leprosy, and the treatment is 12 MB blister packs. So as you can see, this is the picture of the person having PB and MB. Now, multi-drug therapy of leprosy. So, to deal with the response-resistant stains of M. leprae, to shorten the duration of the treatment, and multi-drug therapy with the rifampicin, dapsone, and clofazimine was introduced by the WHO in 1981. So multi-drug therapy in leprosy basically recommended when the dapsone resistance occur in the M. leprae, and when we want to shorten the treatment for the leprosy, and in multi-drug therapy with the rifampicin, dapsone, and clofazimine was introduced by the WHO, or we can say was accepted by the WHO in 1981. Now, the advantage of multi-drug therapy included it can effective in the cases with the primary dapsone resistance, prevents the emergence of dapsone resistance, affords quick symptom relief, and renders multibacilli leprosy causes non-contagious with a few days, and it can reduce the total duration of therapy also. Now you can see the multi-drug therapy of leprosy included rifampicin in multibacillary. We can use it in 600 mg once a month. Supervised, we have to supervise it. Then bacilli, we can use 600 mg once a month supervised. Then dapsone is used in 100 mg daily self-administered. In bacilli, it is used in 100 mg daily self-administered. So we do not have to supervise the dapsone in multi-drug therapy of leprosy. Then the next drug is clofazimine. So clofazimine is used in multibacilli basically 300 mg once a month in supervised and 50 mg daily self-administered. So this is for the clofazimine, and it is not used in fucibacillary. Now the duration of multibacillary of these drugs is 12 months and the pubibacillary is 6 months. Now as you can see, PB adult blister pack. So this is the PB adult blister pack. So PB adult treatment once a month, day 1, 2 capsule of rifampicin, 300 mg into 2, 1 tablet of dapsone, 100 mg. Now once a day, 2 to 28, 1 tablet of dapsone, 100 mg, and for full course 6 blister packs is used. Now, this is the multibacillary adult blister pack. So MB adult treatment once a month. It include day 1 2 capsule of rifampicin 300 mg into 2 and 3 capsule of clofazimine 100 mg into 3, 1 tablet of dapsone 100 mg. Now once a day, days 2 to 28, 1 capsule clofazimine is 50 mg and 1 tablet of dapsone is 100 mg. So full course we have to use for 12 blister package in the multibacillary adult blister packs. Now alternative regimen for leprosy included use only in the case of rifampicin resistance or when it is impossible inedible to employ the standard multi-drug treatment regimen. Now, the alternative regimen included intermittent ROM, rifampicin 600 mg plus ofloxacin 400 mg plus minocycline 100 mg are given once a month for 3 to 6 months for pubibacillary leprosy and for 12 and 24 months for multibacillary leprosy cases. Without any drug in the between, we do not have to use any other drug while we taking this kind of leprosy treatment. Now, the intermediate RMMX therapy, it included RMM is the rifampicin multi-drug therapy. So, moxifloxacin 400 mg plus monocycline 200 mg we can use. Rifampicin 600 mg is administered once a month. Then 6 doses given for the pubibacilli leprosy and 12 doses given for the multibacilli leprosy cases. Now, reaction in leprosy. So, what kind of reaction can occur in leprosy patient? So, lepra reaction can occur. Then occur in lepra LL considers with the institution of chemotherapy due to the release of antigens from the killed bacilli, and lepra reaction is of abrupt onset and existing lesions in large become red, swollen and painful. So several new lesions can occur in these reactions. Malaise, fever and other constitutional symptoms generally accompany and may be marketed or has been seen in this leprosy reactions. Now, the lepra reactions temporary discontinuations of dapsone is recommended and only in the severe cases. Now, all we can use is clofazimine in 200 mg daily is effective in the controlling the reactions of leprosy, except the severe one. Then prednisolone is also used in 40 to 60 mg per day for severe reactions. Now, this is all about your leprosy. So, to eliminate leprosy, we need to detect the patient and cure them with the multi-drug therapy. Now, I have concluded some quiz questions for you regarding this particular anti-leprosy drug. So, you can easily answer these questions while going through the lecture. So, the question included, what are the symptoms of leprosy? Is there a cure for leprosy? How does leprosy affect the body? How is leprosy spread? Does leprosy cause body parts to fail off? Is there a leprosy vaccine exist? How was leprosy eradicated? And is leprosy spread by touching? What is leprosy called now? So you can answer easily these questions while going through the lecture And if you found any kind of difficulty in these kind of questions, so I can give you a detail, or some kind, I can give you some hints of these questions. So we will start with the first question. So first question is leprosy symptoms. So when we say leprosy symptoms, okay, so we can see it. It can shows the patches. So the patches will be in the reddish and reddish or in copper color. So leprosy start by damaging the nerves that is close to the surface of the skin. So the first sign are often like discolored patches on the hand and feet, and that are have a lots of sensation due to the nerve damage and weakness of the muscles in these areas. And then the second question is there a cure for leprosy? So yes, leprosy has been curable by the multi-drug therapy, a combination of three drugs that fight the leprosy bacteria since 1982. So people affected by leprosy usually take multi-drug therapy for 6 to twice a month after diagnosis, depending on their type of leprosy that they have, like multibacilli leprosy or pubibacilli leprosy. So it depends on the patient condition. So multi-drug therapy is provided free of the change by the WHO, free of the charges by WHO, World Health Organization, and to start the better, as they are less likely to develop the permanent impairment as the result of their leprosy. So definitely there is a cure for leprosy. Then the next question is how leprosy affect the body. So it left untreated, if leprosy is untreated, then leprosy progress and the nerve damage spreads. So lacking sensation in their hands, feet, people with the leprosy can injure themselves also, and these injuries are can lead to ulcers, infections, and permanent disability. So leprosy can be caused by muscle paralysis resulting in chewed finger and foot drip. So this makes it difficult for people to walk also and use their hand. So it can also damage the nerves in their faces and cause the eyelid muscles to stop working, as the eye are no longer protected by the blinking, and they are easily damaged, leading to slight loss and blindness. So these are the how leprosy affect the body. And in some people, like they experience the reactions to the leprosy bacteria in their body even when the bacteria is no longer active in the and treatment is underway. So these reaction can cause pain or skin sickness, swelling, and the skin and fever it can also cause. Now the next is how leprosy spread. So leprosy is mainly spread in the airborne droplets, such as through coughing or sneezing or someone who are affected by the disease. However, it is it will only infect those with the poor immune system and who may be undernourished and living in poor hygienic conditions and more likely to develop leprosy due to their genetics, and 95% of people are naturally immune to leprosy. So the next question is, does leprosy cause body parts to fall out? So the answer included, there is no current leprosy vaccine that provides full protection against the disease. But however, there is a leprosy vaccine called Mycobacterium indus prani, that we called in short MIP. so which has been developed in India and is being used by the Indian government as a part of its leprosy control program. So the vaccine is useful but occurs limited protection, and currently research to develop a more effective vaccine is taking place in the USA, and the leprosy mission will be involved in a clinical trial to test its effectiveness. So the next question is, does leprosy still exist? So when we talk about this question, uh, so in like does leprosy still destroy people's life? And yes, in addition to the physical effect of the late treatment of leprosy, which can leave the people unable to walk or carry out everyday tasks, so that disease also affect the people mental health and general well-being. So many people affected by leprosy struggle with the anxiety and depression. So in countries where leprosy is prevalent, there may be like myths and superstitions and a lack of understanding about the disease. So it means that people affected by the leprosy are often subjected to stigma and discrimination. So they can be rejected by their families, friends, and communities. So many people lost their jobs and struggle to find a new employment, and other though lost their homes to find themselves excluded from the school. So the next question is, how does leprosy eradicated? So when we talk about the how does leprosy eradicated, so the basically a simple answer is by taking proper care and proper care of the patient, and we do not have to discriminate them, and we have to use the multi drug therapy for the patient. So where is leprosy found in the world today? So when we see, does leprosy still exist? So the country with the higher number of new leprosy diagnoses every year are included like India, Brazil, and Indonesia. So more than a half or all new cases of leprosy are diagnosed in India. And in 2018, like 12 lakh 334 patient or 57% new cases of leprosy were found in India only. So in 2018, there were 15 countries reporting more than 1,000 new cases of leprosy. So these were like Bangladesh, Brazil, and Ethiopia, India, Indonesia, Myanmar, Nepal, Nigeria, Philippines. So these are all developing countries. So there maybe leprosy conditions are more because of the poor hygiene, poor diets, and the living condition of the people. So the World Health Organization provide full static on new cases of leprosy. So there should be one questions also arise in the people's mind, that when will be leprosy eradicated. So its simple answer is like leprosy is a complex disease, and it is also the like slowest growing bacteria. So which means research to help us in need, and the disease in challenging. So since leprosy also affect the certain animals, it will be very difficult to eradicate the disease completely. But with the new tools, way of working, and increased political commitment, it is possible that we will be able to end the human transmission of leprosy. And there is a hope that we could stop the leprosy transmission in our lives. And although it is will require the significant investment in the research and to achieve this, and this meantime there is no reason why leprosy should result in disability. It promptly treated by the drugs, and we have lots of drug to treat leprosy. Now, one more question is there. What is leprosy called now? So when we talk about this question, so sometime people called it leper. So leper is an offensive word with which contribute to the stigma surrounding the leprosy. So it is the word that is associated with someone who is like an outcast and who can be rejected by others, has been used to justify the trouble or treatment in the discriminatory law. And when we talk about the can animals get leprosy, so yes, some animals go get leprosy, such as like red squirrels, monkeys, and they can have a leprosy. And can leprosy be transmitted from animals to humans? So yes, it is very rare for animals to pass leprosy into human, but it can be possible, and thus usually happen when like close contacts has happened, and such as by keeping armorites as a pets and eating them, and the vast majority of leprosy patient can be infected by other humans. Now the next question is leprosy spreaded by touch? So yes, it can be spreaded by touch. So these are some common questions regarding leprosy. And now when we say how long can you live with leprosy, so this is also a common questions arise in people's mind. So currently leprosy is a treatable with the combination of multi-drug therapy like antibiotics therapy, and the last for about 6 months or 2 years depending on the existence of the disease on the individual patient. And how was leprosy eradicated? So leprosy is a curable with the multi-drug therapy. So untreated, it can cause the progressive and permanent damage to the skin, nerves, and limbs and eyes, but it can treated by the multi-drug therapy. And what is leprosy called today? So leprosy is also known as Hansen disease, also known as leprosy, and it is an infection that is caused by slow growing bacteria called Mycobacterium leprae. So the second name for leprosy is Hansen disease because the scientist Hansen discovered it. So I hope you get all your answer. I try to give all the questions answer very vastly. Now this is all about your today's lecture. While going through the references, so we have taken these all information from the Basic and Clinical Pharmacology by Baritum G, Katberg, Sunsen, and then also from the Elsewhere Integrated Review Pharmacology by Mark Kester, and some of taken from the Pharmacological Basis of Therapeutics. So on other information also you can go for KDT and Goodman's book for the better knowledge of these topics. And this is all about your leprosy. So I hope you get a good knowledge about the leprosy. So thank you for today's lecture. Thank you for kindly listening to me. This is all about your today's lecture.